Yeah.
Next question is, which is better, a fresh or frozen embryo transfer?
So it depends on the situation.
Mm-hmm.
We do a lot of frozen embryo transfers in our field now because it's one of the major reasons why ovarian hyperstimulation syndrome has become less of a problem. It's something that I talk to my patients about way less. It's, in the back of my mind, of course, it can always happen. But the reason why ovarian hyperstimulation syndrome, which used to be a major complication of IVF, is less common, one of the major reasons is because a lot of the cycles we do now involve just freezing all the embryos and allowing all those high estrogen levels and that unnatural
To come
environment
down,
of having, to just come down back to the normal baseline 1 to 2 weeks after the egg retrieval. You get a period, your ovaries go back down to their normal size. And then in a calm, controlled fashion, put the embryo back into a more natural, stable environment so that when the HCG is produced from what we hope is an early pregnancy, if that transfer works, which we hope it does, that HCG can't continue this cascade where HCG can actually stimulate the ovaries and continue to produce those high levels. And it can wreak havoc on your body if you have hyperstimulation syndrome because it makes your capillaries leaky. So you end up getting really dehydrated, gathering fluid in the abdomen. All of these things sound very scary, but I can assure you they hardly ever happen now because we're not doing bunches of fresh transfers. Back in the day, fresh transfer was the best bet because we didn't know how to freeze embryos well.
Right.
And there was no reason to really be freezing all of them. We were doing multiple embryo transfers and trying to, really maximize the chance of success because we didn't have good ways of picking the healthiest ones.
Right.
Now, I'm not saying that you always have to do genetic testing, but a lot of people are doing genetic testing, which has greatly improved the success. And a lot of other advances have improved the success. And we've been able to put back one healthy embryo at a time. And by doing it in a more natural environment, reducing the risk of OHSS. And it also has been shown in patients who have a high ovarian reserve, so they end up getting really high levels of hormones because they have so many eggs growing. If you do fresh transfers in those patients, in addition to the risk of hyperstimulation syndrome, the overall chance of that embryo implanting is about 10% lower than in a cycle where it's a calm, controlled, natural environment and it's a frozen, thawed embryo. So a lot of people think freezing and thawing the embryo is going to hurt my chances, but it's actually the opposite. So
isn't it crazy how it's totally shifted, like just with technology? Because I remember when I trained, I mean, it's awesome. To think about that, because I did residency in 2004 and a community-based program. So my faculty were private practice docs, and the number of ovarian hyperstim cases we had in early pregnancy with patients, I remember I got to be a pro at helping manage it because we saw it all the time. And, there were some pretty sick patients and I'm not saying all cases get that way, but it used to be that way. So the way that we've been able to swing the pendulum a little bit to have it more controlled and hopefully prevent that significant complication is just incredible. And then just like you said, showing that it helps actually to have that pause can even improve your outcomes is even more
obstetrical outcomes. There's some data that suggests higher risks of preterm delivery with fresh transfers in patients that have had really high estrogen levels because it's a less natural environment. So the placenta probably doesn't get to implant as deeply because the lining of the uterus is less receptive to the embryo in the early stages of implantation. So higher rates of preeclampsia, preterm delivery, like all these other things that you wouldn't think of. Even ectopic pregnancy is more likely after a fresh transfer. So large majority are frozen transfers. Reasons I still do a fresh transfer sometimes, if a patient has a very low ovarian reserve and I'm not worried about hyperstimulation, right? And I'm worried that they're not going to have embryos that are available to be frozen. Maybe they've done a cycle before and all of the embryos were very slow growing. In that case, it might be better to just put the best one back on day 5 and hope for the best. But it's never my first choice.